having in the vocal cord. I'll just again run. This is the type of vocal cord dysfunction. Again, no time for video, but this is the type of voice that you should hear. The person is speaking pretty okay, but at the same time, while inhaling, you can hear the noisy enveloping stridor. This patient has walked to the OPD and not in an emergency situation, but very much likely to have it when she breathes in. There's a stridor to this. And when you examine these vocal cords, if they were in bilaterally paralyzed, they would have been in absolute median position, but they are actually giving a chance because they are not in bilateral paralysis, not in median, but in paramedian position. And this is because we have a predominance of, thankfully, the adductors of the larynx as opposed to a single abductor, which is a post-PCA. So even if the PCA is a bulky muscle, it does not have a more dominance over the adductor muscles, and therefore the vocal cord paralysis is not that pronounced even in a bilateral one. Also, the ipsilateral muscle, which is the cricothyroid muscle, helps the muscle tense away from the adductor position. So these are two hypotheses that we were made to study in our younger years, and you must know these processes. There can be a question on this, the Simon's law and the Wegener-Grossman processes. But over a time, there have been scientists like Crumley who have brought out the prosthesis of this hypothesis of synkinesis, that over a period of time, the vocal cords tend to medialize, and unilateral cords, in case of unilateral paralysis, there's a compensation that occurs over 5 to 6 months, whereas bilateral paralysis becomes more worsening over time. So you must have seen that over a period of time, the unilateral cord becomes better and a bilateral becomes more worse. And why the paramedian? It is explained through the synkinetic re-innovation. You can read this chapter in Laryngol 2000, which is by Crumley et al. So, vocal cord paralysis, as you can see, I'll play this video at least, it is basically more of a symptom. Now you're seeing this and you'll be very happy to diagnose that this is a unilateral vocal cord paralysis, but why it is happening and whether there is a joint immobility, as Dr. Gulati also said, so exact cause must be found out. When it comes to causes, there are more important to know that for recurrent laryngeal paralysis, there's 26% to 27% are idiopathic causes. We really don't know. We have not come across the real reasons, but we said viral infections and all these things can happen. But there's a considerable now amount due to good detection of malignancies which are there in the lung or in the neck. Also traumas, intubation, which is coming out to be an important reason for it, as well as iatrogenic 8% causes like surgeries, mainly like thyroidectomy, and then neurogenic causes and reasons. But it is important to know at what level the damage has happened, supranuclear, nuclear, whether it is high vagal lesions, and whether they are low vagal lesions, which are more common in our scenario. Also, you must know whether it's systemic causes like diabetic mellitus, diphtheria, typhoid, and then various causes like idiopathic. This is an important table for you. If you have a right-sided, if you are asking question telling that there's a right side cause, then the neck trauma or iatrogenic causes, or in carcinomas, the carcinoma apex lung becomes more important. On the left side, you have mediastinal causes and causes of thorax more important. And then of course both cords can be important. So basic protocol, very quick, these last 2-3 slides. We have to do some elementary diagnostic procedures, we have to have clinical diagnostic aids, and then additional measures. Nothing to beat the history and examination, these exact causes that I said, so a good history is absolutely important. And there you can, as a person, first make an assessment through the scale called the Garbas scale, or which tests the grade, the roughness, breathiness, asthenia, that is weakness, and the strain in the voice. And 0, 1, and 2 grading can be done for each parameter. After that, you have auditory perception tools like multi-dimensional voice software, you have stroboscopy, high video imaging, things like that. You have enough seen things on stroboscopy, but stroboscopy helps in directing fine neurological activity also when you are doing it through these tests. But very important, which again will come in the exam, what is the single radiological investigation for maybe a left side vocal cord paralysis, which you are trying to find out. It will be definitely a contrast CT scan for intrathoracic lesions, and if you have to get an MRI done for CNS, supranuclear, intranuclear, it will be of brain and skull base sometimes. CT neck may be done if there is a possibility, a strong possibility of a lesion in the neck, which is a very malignant lesion. Dr. Gulati mentioned about electromyography, and this is a very upcoming tool, been there for many times, but in its finer version with Medtronic softwares and all, it is helpful. Of course, spirometry and other aerodynamic assessments are important. I will not go now into details of LNG because I wanted to do it and give you some questions, but you're most welcome after that. So treatment of UVCP is to ensure that phonation comes in, but in bilateral cords is for airway. And UVCP, that's unilateral, is mostly elective, whereas bilateral is an emergency procedure. And in UVCP, you have to wait and watch. As I said, synkinesis can make the vocal cord function better, and you can treat it with, on the temporary basis, with injection laryngoplasty, with medialization thyroplasty using an implant. It is called type 1. You can do an AA adduction for wider lesion. The question can come is the glottic change is wide, you can do adduction, and these days re-innovation procedures are also helping out. In bilateral, you will do, if possible, required a tracheostomy, otherwise an endoscopic suture lateralization using a Leichenberger's needle. A posterior transverse podectomy is done, which is also known as Kashima's procedure, and then an electric pacing. So these are the approaches that can be done. And I'll leave the video again. Hyaluronic acid, calcium hydroxide gel, collagen. Fat is the most common one, which can be autologous. This is how the thyroidoplasty implants are done. And this implant, which is a titanium implant, is called Fried's implant. And this is a pre-fashion implant, but a good silastic block is the commonest that we do. This is the window you make for the type 1, and this is the AA adduction, where you actually detect where the vocal process is, and the muscular process, you take a switch figure of 8 and take from this window out and then tighten it. So this is the Woodman's procedure. It used to be very common in our hospital here in Maulana Azad. Dr. Gulati himself taught me this procedure long ago and very helpful. This is the cordectomy that was I talking about. And in this we are using a laser. See, this laser is being used to give a cut. First is a transfer cut just near the midline. Why we are not removing the whole vocal cord, but because for phonation we need the anterior part of the membranous vocal cords to survive. For phonation, we are making a keyhole, removing this, and then this later on the whole thing becomes from the side coming down like a pyramid. You remove, and even a partial arytenoidectomy is done with that. Can be done with correlation. This is the new thing you may be asked, is the RLN and the ANSA anastomosis. This will not restore the function. You plant this Tucker maneuver technique, you remove the cartilage a bit and plant the nerve directly on the PCA muscle, or if you can identify the inner nerve, you can plant it there. This helps to bring the bulk back and give better results in the long run. This was one of the pictures that I had done, but we'll talk about it. And nowadays, what? Laryngeal pacemaker, like in you have in OSA, you have laryngeal pacemakers now in trial stages. They have done 3 laryngeal pacemakers on people, and they have helped really in the movement of the vocal cords as well as the bulk. So there is an article on this. You can read this article in Laryngoscope 2010. It's not that recent, but it is a very good article. And of course, in children, it is one last slide important that should not be missed, because 10% of all congenital anomalies may have a laryngeal paralysis, and bilateral is actually also there. And for this, make sure all these parameters that we have said, codectomy and all, are not indicated. So nowadays, which technique in children is indicated? There is only one surgery which I do a lot, and that is displacement of the posterior ethmoid. We do a partial cricoid section and then place a costal cartilage in that. So it is called the Rutter's technique, in which you do not do any damaging cuts on the vocal cords, because in children the vocal cords will regenerate very fast and lead to paralysis very soon. So conclusion is that different type of cordectomies are providing new precise results.